Hi, this is Andrea, and I'm here with you for HIT 210, and we are on week 16, and this is a lecture video on chapter 18, Ambulatory Surgery Centers. And if you want to follow along in your textbook, we're on page 428. The reason we're talking about ambulatory surgery centers, and then in chapter 19 we're going to talk about hospital outpatient departments and areas, are because those are places that an MA could be employed. And so you would need to know about those things. The really cool thing about chapters 18 and 19 are that they bring together so much of what we've already learned. And so you'll be able to apply it and it'll kind of all tie together. So let's talk about ambulatory surgery centers. If you look at your syllabus, you'll see that we're on unit objectives 9.4.1 through 9.4.10 and 9.5.1 through 9.5.3. But if you look at our book, the objectives we're going to focus on this week include explaining the revenue cycle process for ASCs, describing the components of the ambulatory surgical payment system, understanding the impact of LCDs and NCDs, that's local coverage determinations and national coverage determinations, and how they fit in with the ASC reimbursement cycle. We have a discussion on NCDs and LCDs, but we'll also talk through them as we move through the slides. The last two learning objectives we're going to focus on are recognizing the reimbursement methods used when determining various payers for ambulatory surgical services and identifying the ASC QR measures, ambulatory quality reporting measures, and the effect that they have on ASC payment rates. For instance, what happens if an ASC does not report those quality measures? Or what if they report quality measures, but they do not meet the established thresholds? That's when it can really have an impact on those ASC payment rates. So the first thing we need to do is establish what exactly is an ASC. And I've included this here in the website link. It's at the top right. And there's a video here that I'm going to click to in just a minute. But anyway, an ambulatory surgery center, they are modern healthcare facilities focused on providing same-day surgical care, including diagnostic and preventative procedures. ASCs have transformed the outpatient experience for millions of Americans by providing them with a more convenient alternative to hospital-based outpatient procedures, and done so with a strong track record of quality care and positive patient outcomes. They've also done it at a much lower cost. And that's one of the biggest attractions about an ASC, is that the cost is lower. And it makes sense if you think about it. With a hospital, you have so much overhead, and you have so many other things going on that are costing the organization, whether that's staff or a facility or equipment, all those types of things. And with an ASC, you simply have the ASC itself. So let's take a look at this video here. Hang on a second while I change screens and get out of what I'm in. All right, so let's go over here and we'll play.
What is an ASC? Ambulatory surgical centers, or ASCs, are modern medical facilities that provide outpatient surgery. Thanks to modern anesthesia and surgical techniques, many procedures that once required a hospital stay are now safely performed on an outpatient basis. What that means is that patients can leave the facility the same day as their surgery and recover in the comfort of their own home. Procedures performed in ASCs include eye surgeries, colonoscopies, spine and joint procedures, and many more.
And because ASCs focus exclusively on providing outpatient surgery, we are able to provide a comfortable and efficient experience for our patients.
The doctors and nurses who work in ASCs have the same education and training and credentials as those who work in the hospital. And just like hospitals, ASCs are regulated by the state and federal government to ensure patient safety and quality outcomes.
ASCs also deliver value. We provide the same high level of care as the best hospitals, but we do it at significantly lower cost and with less out-of-pocket expense for our patients.
Hi, I'm Bill Prentice, Chief Executive Officer of the Ambulatory Surgery Center Association. We are proud of the exceptional health care that ASCs provide to millions of patients each year, and invite you to learn more by visiting our website, advancingsurgicalcare.com. More importantly, if you or someone you know needs outpatient surgery, I encourage you to talk with your physician about receiving that care in an ASC. You'll be glad you did.
Okay, so let's go back to where we were and move on. The history of ASCs. Why did they get started and when? It's actually in the 1960s that the whole concept of ASCs were explored. 1970s, they really started being built. 80s and 90s, they expanded. And why did that happen? Well, the reasons for growth of ASCs include that there are reduced healthcare costs for patients, physicians, and payers. There's greater convenience for physicians and patients. They have the same quality and safety requirements as hospital-based outpatient surgery, outpatient care centers. With the expansion of surgeries and services performed due to technological advancements, more and more patients and physicians can take advantage of ASCs. So, for instance, procedures that used to be done on an inpatient hospital basis are no longer done that way. I can remember when eye surgeries and GYN surgeries and hernia surgeries, appendectomy is a little bit different, but cholecystectomies, some of those types of things, especially elective procedures that you get into with orthopedics, those used to have to all be done in a hospital. They aren't anymore. Most of those are in and out procedures, same day, whether they're done in a hospital setting or an ASC. Another reason why ASCs have grown is that there have been delays in obtaining outpatient surgery advanced technology within the hospital setting. Sometimes in hospitals, the competition for resources and money and technology that's spread across the hospital. That includes the intensive care unit, that includes the ED. In an ASC, you're not competing with those other departments to get your advanced technology. And so there's not the delay or the competition that would result. And it's a little bit easier for those physicians to be able to have that kind of technology and the equipment that they want to be able to do these surgeries there. And then there is opportunity for owner profit. A lot of the physicians ended up buying into ASCs and they made money off of it. And because of the opportunities for efficiency, for patient convenience, patient preference, it attracted physicians to be able to do procedures there. So there were a lot of really good reasons. It attracted staff because typically ASCs are Monday through Friday and they don't stay open past 6 or 7 in the evening. So it's a place that nurses want to be employed and other healthcare givers because of that. I included this information about ASCs because, and it's on the next couple of slides, it has to do with ambulatory care and why it continues to grow, and it builds off the last slide really. But with innovation and technology, there's been advances in clinical approaches and technology, especially when it comes to anesthesia and pain control and minimally invasive surgical procedures. And so procedures can be done in the ambulatory setting in an ASC, as I said, that weren't able to be done years ago. Consumer demand. Consumers are increasingly concerned about having lower costs, improve access, better experience, and they find that sometimes in settings that are outside of the hospital, the traditional hospital. And so ASCs can provide those things to patients. There's more convenient parking, sometimes there's even valet parking. There's the facilities designed specifically for ambulatory surgical care and for the waiting area and the flow. It's very different than retrofitting a hospital. The other point I want to make about this information and why I included it is it gives this example down here that Blue Cross Blue Shield's Health Report of America estimates that when members elect to have a hip or knee replacement performed in an outpatient facility, costs can be 30 to 40% lower. On average, the price of an inpatient knee or hip replacement was $30,000 compared with $19,000 and $22,000 respectively in the outpatient or ambulatory surgery setting. Sometimes these preferences have been reinforced by COVID because some consumers feel they are less comfortable returning to hospitals or emergency rooms because of the pandemic. So you can see that there's multiple reasons why. I want to move on to the next slide because it continues what we were talking about. There's also payer pressure. There's new incentives for providers and payers to find the lowest cost sites of care. And so when you're looking for a lower cost, typically that's outside of a hospital setting. Hospitals are high cost settings just by the nature of the beast that they are. And so that's another reason for growth in ASCs and continued future growth. It's sort of like what we've seen with COVID and telemedicine, how telemedicine has just exponentially grown because of COVID and will likely continue to be utilized because of convenience and less cost and all of those other things that go with it. And then there's provider opportunity with ASCs. A lot of times there's shared ownership. And so that allows physicians who are equity owners in ASCs to have a financial benefit from it. Now, granted, they have to disclose the fact when they're referring patients to an ASC that they have a financial stake in, they have to disclose that. But that's where they like to practice, and there are so many benefits to the patients that, as long as the patients are informed, a lot of times they're very comfortable with that. And especially when you're talking about relatively healthy patients where they're coming in, they're getting that procedure, they don't have a lot of complications or comorbidities, they don't have a lot of severe disease concerns or risk factors that would mean that they might end up needing to go to a hospital. So again, a lot of that is screening which patients really are good candidates for an ASC versus which ones are not. I wanted to include this slide as well because it shows side by side the required health and safety standards under Medicare for ASCs versus hospital outpatient departments, and they're identical. ASCs and hospital outpatient departments are both required to have compliance with state licensure laws, have a governing body and management, have surgical services, do quality assessment and performance improvement, manage their environment safely, have a medical staff with established policies and procedures that go with that, have nursing services, medical records, maintain medical records and content of medical records, pharmaceutical services, lab and radiology services, patient rights, where you're talking about, for instance, privacy practices and other patient rights. Infection control is the same at both, the requirements of what has to be monitored and how the rooms have to be set up. The surgical area has to be monitored in terms of humidity and temperature and negative air pressure, those types of things to reduce infection. They have to have patient admission, assessment, and discharge processes, forms, documents, all of that has to be involved. And they also have to go through emergency preparedness, make sure that they've got all of that in place to manage any emergencies that happen. So it's again, affirmation that both ASCs and hospital outpatient departments are both required to maintain complete and comprehensive and accurate medical records that include a medical history and physical examination relevant to the reason for surgery and type of anesthesia planned. The physician also has to examine the patient immediately before surgery to evaluate the risk of anesthesia and the procedure to be performed. And prior to discharge, each patient must be evaluated by a physician to ensure it's safe for the patient to leave the facility. That's true of an ASC and a hospital outpatient department. Those are Medicare requirements. And in many states, Medicare certification is required in order to obtain state licensure, and all Medicare certified ASCs have to fully comply with state ASC laws. So the feds and the states are both agreeing that whether you're an ASC or a hospital outpatient department, you have to meet all of the requirements of both, which are identical. The CMS also requires that ambulatory surgery centers have a program for identifying and preventing infections, maintaining a sanitary environment, reporting outcomes to proper authorities. They have to be actively doing surveillance. They can't be looking backwards. They have to be actively doing it and have specific procedures in place for prevention, early detection, control, and investigation of infectious and communicable diseases, which is all in line with the CDC. They have to have a registered nurse trained in the use of emergency equipment and in cardiopulmonary resuscitation, CPR. Whenever the patient's there, they have to have a crash cart. They have to check their crash carts daily, all of those types of things, to make sure that there's nothing expired and that all the equipment and supplies are there. They have to have an effective means of transferring patients to a hospital in the event of emergency. If something does go wrong, they have to have a plan and an agreement in place of, do they call the local EMS? Do they, how do they get their patients back to a hospital? How is it done quickly? All of that. They have to have written guidelines outlining arrangements for ambulatory services, transfer of medical information, written transfer agreement with a local hospital, or all the physicians performing surgery in the ASC must have admitting privileges at the designated hospital. And they have all these things have to be in place before the ASC can even open and function, and they have to be done on an ongoing basis. But ASCs rarely have situations where they admit to a hospital because they screen the patients that go to an ASC. An ASC is only for patients that are able to be in and out the same day. So if there's any indication that you're dealing with a patient that is going to potentially have issues with the anesthesia or with the procedure itself, or they've got some risk factors, those patients, the physician has to refer to the hospital outpatient department because they have to be there due to the risk. But if they're relatively healthy, the ASC is a great place for that. And then there are requirements for continuous quality assessment and performance improvement as a means of ensuring patients are receiving the best care possible. And medical staff have to actively participate in quality of care and quality of care improvement. There has to be a performance improvement plan that ensures patients receive the highest level of care. There are a couple of different types of ASCs. One is a totally independent one. This is freestanding, privately owned. It's not integrated or directly associated with any hospital, although they have to have a transfer agreement. They're not included in a hospital's cost report. And then the other type is a hospital-based ASC, where the hospital is affiliated with the ASC is affiliated or owned by the hospital. They're included on the hospital's cost report. These ones are freestanding sometimes, or they can be located actually within the hospital complex. But both types have to be certified. They require state licensure, and typically accreditation is done by the Accreditation Association for Ambulatory Healthcare, AAAHC. So let's stop here and do a couple of quick quiz questions to make sure that we're catching the content. So what are ASCs? When were ASCs created, and why were they created? And then let's think about what might be some advantages of an ASC for patients, physicians, and or payers, and what might be some disadvantages when it comes to an ASC for patients, physicians, or payers. So be thinking about those questions because that'll really summarize what we have been learning so far. All right, moving on to Medicare, ASC, and reimbursement. It's all Medicare Part B if a patient has Medicare, because Medicare Part B covers outpatient and physician-based ambulatory services, which this is. Ambulatory is outpatient. The patient payments are going to be based on Medicare rates. All the services are identified with CPT-4 and HCPCS codes for all payers, regardless of that. The ASC must agree to accept Medicare's payment as payment in full for defined ASC services. And Medicare reimbursement is based on what are called APCs. That's a grouping system for outpatient procedures. And we are going to talk about that when we get to chapter 19 slides. I have a couple of slides there for you, and we'll get into exactly what is an APC. But that's essentially what Medicare reimburses ASCs for. They look at all the procedures, they package those up into different APCs, and then they pay for those on a particular basis where, for instance, they pay 100% for the first one and 50% for the second one, and so on. There are other types of ASC reimbursement. Some patients are self-pay. So one of the challenges is collection can require significant work and cost, and the policy and fee schedule needs to be provided to patients before their visit. Capitation is another type of ASC reimbursement. That's a fixed amount of money per patient per unit of time and paid in advance. There is also fee for service, sometimes paid. Sometimes payers choose that for ASC reimbursement. It is the most common payment model in the U.S., and services are paid for after they are received. It's more of a traditional setting. Capitation is fairly new and rare. Fee-for-service is the most common. So let's talk about those payments. Medicare's ASC reimbursement includes services performed by the ASC facility as well as the cost of the physician's professional services. So there's those two components. There are surgical procedure rules when it comes to ASCs. There's actually a list of covered surgical procedures. These are surgical procedures with no significant safety risk, and they're not expected to require an overnight stay or any observation care after post-anesthesia care. And so it has to be one of those when it's performed in an ASC setting. Another thing to be aware of, the surgical procedure itself may be covered, but not when performed in an ASC. So that's one of the things that with a payer, Medicare or otherwise, that you need to check is whether or not the procedure is covered, but whether it would be covered in that ASC. The procedure or service must be considered medically necessary and not on the inpatient only list for Medicare. Medicare has an inpatient only list, and those are pretty intensive procedures that absolutely have to be performed on an inpatient basis in a hospital setting. If a procedure or service is not on that list, then it may be able to be performed in an ASC, but again, you get back to medical necessity, which we talked about in week 13. And so that's got to be taken into consideration. And then Medicare will not pay for any procedures that meet any exclusion criteria. So quick quiz questions here. Which Medicare Part, A, B, C, or D, covers ASC services? True or false? All surgical procedures can be performed at an ASC. True or false? All surgical procedures performed at an ASC are covered by the payer. Let's think about those. All right, moving on to the ASC revenue cycle. In terms of pre-service, you have pre-admission where you're getting patient information, you're verifying their eligibility of insurance benefits, and then there's pre-authorization. You get that pre-certification or referral from the insurance company, that precious number that says, yes, we have gone through this and we believe it's going to be paid. And then the service, of course, has to be medically necessary. When it comes to post-service, you've got your actual service or procedure provided. All that documentation is completed. Your coding and billing activities get performed, and then you move on to receiving the payment. And that's when you need to review the remittance advice to ensure that you were paid the correct amount. There may be some aspect of collections to do, and a lot of ASCs hire billing contractors or billing contract companies to handle their collections. And then if there's an appeal, the insurer has to report why the claim was denied or reimbursed at a lower charge. They have to state how and when their decisions can be disputed. So let's talk about those ASC medical records. First of all, you have to have a complete chart, whether that's paper or electronic. You have to have a complete patient chart, and that means you have a history physical report, an op report, test results, anesthesia record, any flow sheets, like vitals, things like that. Discharge instructions, and then any payment and benefit plan agreements, insurance identification, verification, authorization, those types of things. ASC coders review records and assign appropriate CPT HCPCS codes, ICD-10 CM diagnosis codes, modifiers, and status payment indicators. And then they also require knowledge of ASC coding in accordance with ICD and HCPCS coding rules, proper billing procedures from both Medicare and private payers. So there is diagnosis coding, ICD-10-CM, which we did in Chapter 12. There's also procedure coding, and this is CPT, and we did that with Chapter 13. The first listed procedure can be therapeutic or diagnostic. It's typically the highest paying procedure. The CPT codes are entered in descending order or reimbursement, and then the provider has to be sure that they document diagnoses for all those services that were provided. Again, it's justifying that medical necessity. It's saying, here's why we did what we did. And then, of course, there's modifiers. And when we were in Chapter 13 and we were talking about CPT, we talked about some of these modifiers. And this list is not complete. It's just to give you some ideas, because, of course, modifiers do get changed over time. When it comes to claims management, and we just did this just a couple of weeks ago, week 14, I think it was, that we talked about CMS 1500 forms, and you had to practice filling one of those out. Well, when it comes to ASC, there are a couple of fields that absolutely have to be completed, and that includes field 23, 24B, and 24D. And so they just list those here. And then on the UB04 form, which we talked about, they have some other information that needs to be there, but the most important part is box 42 or 490, where you have the revenue code that's used to report ASC care. So some quick quiz questions. Which types of codes are used to report ASC diagnoses, procedures, services, and supplies? There should be, you notice there's types, so there should be at least two that you're talking to me about. What are some forms or documents in an ASC medical record? We briefly reviewed those. True or false? There are specific modifiers approved for ASC use. And true or false? There are specific fields on the 1500 and UB04 claim forms to identify ASC activity that must be completed. National Correct Coding Initiative efforts. This is another one of our discussions this week. NCCI and MUE. So NCCI is National Correct Coding Initiative, and there are edits that go with that. And why these were developed, sorry, I'll get it out here. These were developed to control improper coding that led to wrong payment in Part B claims. And this is where we get into bundling or unbundling. And we studied that, was that last week, the week before? But recently we've talked about bundling. And so this is where they have edits in place that the claim goes through, and they're looking to make sure that there's not unbundling happen. Only the more comprehensive code is covered, and there are some physician edits that apply as well. LCDs and NCDs, I promised you we would talk about that, and here they are. LCDs are local coverage determinations. NCDs are national coverage determinations. Let's talk about NCDs first. These describe the circumstances for Medicare coverage nationwide. They are for a specific service, procedure, or device, and they define the conditions to determine if the service is covered. When you do your discussion, you'll actually go out and take a look at those. Local coverage determinations are a decision made by the MAC, the Medicare Administrative Contractor in a particular region, regarding whether to cover a particular item or service on a MAC-wide basis, not a nationwide, but a MAC-wide. It's used when there is no NCD or when there's a need to further define an NCD for that specific region. And MACs like to develop these, and then they'll take turns sharing them. So you may find that a MAC that's in one region is actually utilized by a MAC in a different region as well. But it's really important for us to know who our MAC is in the region that we're in if we're involved in coding and billing. And also know their website and know where to go to look for these LCDs. All right, so ASC quality reporting. This is the last part of Chapter 18 we're going to talk about today. This is the Ambulatory Surgery Center Quality Reporting Program, or ASCQR. The ambulatory surgery centers have to report quality of care data for standardized measures in order to receive their full ASC payment rate. This is part of the value-based purchasing program that we've talked about briefly before. And there are quality measures that are goals for quality improvement and accurate decision making. I'm sorry, let me back that up. The reason why there are ASC quality measures are you can set goals for quality improvement and make accurate decisions. It also improves efficiency and patient satisfaction. So they're looking to make sure that ASCs are not just getting by, but actually trying to improve. And they're doing it by measuring and really looking at the data, drilling down, and making decisions about what needs to be improved and how to improve it. And that is it for Chapter 18. All right, I have a lecture video for Chapter 19, so hopefully you'll get a chance to see that, and we'll talk again soon. If you have any questions, be sure and shoot me an email. Thanks.